If you have any question, oh, it's not moving. Let me see. Okay, it works now. So I'll talk to you a little bit about how to build a program of research, especially when you're starting. I'm going to give you some examples of um, how to, a concrete research project that we're doing. And also, I'm going to talk a little bit about the future research. So I'm going to show you a conceptual framework that my team's work is mostly focused on. And then we are trying to understand how to deliver better care to patients. So that's why patients are embedded within multiple levels. So this model is called socio-ecological model. So my team and I study patient outcomes, especially patient emergency department use, and trying to understand how we can predict these outcomes. But we also study that the teams and clinicians who deliver care, we know that patients are taken care of by clinicians and by teams, and depending who these teams and who these clinicians are, is going to affect nurse practitioner patient outcomes. And then we also study organizations because nurses, healthcare teams are embedded within healthcare systems. And if organizations are not doing a good job of creating good environment for clinicians, then they're not able to deliver good care to patients. And then that's going to affect patient outcomes. And finally, we also study communities and the environment because we know that larger factors that are in the community, in the environment, affects healthcare organizations. Healthcare organizations affects clinicians and teams, and it ultimately determines patient outcomes. So this is kind of an overall summary of various, kind of bringing our projects together. But most of our work is, and I see some messages on the chat. I want to make sure, Eka, everything is good. I want to make sure people can hear me. So that's good. But most of our work is motivated by the fact that a lot of people in the US, Americans are getting older, and we need to find a way how to deliver good primary care to older patients in the US. And some estimates show that by 2030, which is in a few years, about 73 million Americans uh, will be 65 years and older. And this number is going to reach to 86 million by 2050. As you can see, people are getting older, more people and proportion of the population is getting older. So healthcare system faces challenges to deliver care. And we also know that people who get older, they require more care. So in this graph, you can see that people who are 18 and 44, they consume less healthcare services, and people who are 75 plus and older, they consume more healthcare services. So older people need more healthcare, and healthcare system have to try find a way to deliver good care to these patients. But one of the biggest issues in the US is that a lot of physicians, residents, do not want to become a primary care physician. And there is a big shortage of primary care physicians in the US. Some estimates say between 18 to 50,000 physicians are going to be needed in the US to deliver care. Why people don't want to become physician is because they're not paid well. And there is a big salary gap between primary care physicians and if specialists. Let's say if someone is going to go become a radiologist, surgeon, and also burnout is very high among physicians. Some studies say that up to 50%. Can you please mute? I'm hearing it from you. Yes? Okay, good. Thank you. Up to 50% of primary care physicians are burnout. And they also spend a lot of time on doing non-patient care tasks. So for these reasons, physicians are not residents and fellows do not want to go and practice in primary care. But what we are noticing in the US is that primary care workforce is changing. And nurse practitioners are delivering large proportion of primary care in the United States. Some say that about 47% of primary care is being delivered by nurse practitioners in the country. Right now in the US, there are about 450,000 nurse practitioners. and about 280,000 primary care physicians. And many, many studies have demonstrated that nurse practitioners deliver good quality care and their outcomes are comparable to those of physicians. So, who are NPs? NPs are in the US are registered nurses, so they have a bachelor's degree already. They have a registered nurse, and then they must complete either a master's of nursing degree or a doctoral degree to be able to practice as a nurse practitioner. And they are able to deliver a wide range of services in the US. They can order diagnostic tests, they can diagnose and treat patients, they can prescribe medication. So they can do deliver the whole continuum of primary care to patients. And interestingly, nurse practitioners are the fastest growing workforce in the United States. In this figure, you can see that these are a number of different types of professions in the country. And you can see that nurse practitioners are among the fastest growing, like number 3, I think, fastest growing profession in the United States. In the next figure, I'm going to show you how fast this workforce is growing. You can see the numbers in 2000 and you can see the numbers are in 2025. As you can see how fast NPs are continuing to grow. When I got into this workforce, very early I started noticing this. I published this paper in 2012, 14 years ago. And I said, we need to pay attention to this workforce because their numbers are growing. I told even, about 15 years ago that we need to pay attention how this workforce is growing because they can play a big role in delivering good quality care to patients. And after this, I'm going to show you a lot of studies that we have done that shows how we started studying nurse practitioner workforce. I'm going to show you one of my team's papers we published last year, I think in 2025. We wanted to see, okay, now that there are so many nurse practitioners in the US, 450,000, where do they work? Who hires nurse practitioners? What clinics hire nurse practitioners? And where are these clinics located? So we got data from all nurse practitioners in the United States, all primary care practices that hire nurse practitioners. And we wanted to see if the clinics that hire NPs are different than clinics that do not hire NPs. If you look on this table, you can see that practices with NPs compare those without NPs were more likely to be in the communities that had low income. So it seems like the clinics often hire NPs that are located in the poor neighborhoods. They're also in the rural areas. And also, a lot of people in those communities did not have high levels of education. So what we are seeing in this study that clinics that hire NPs are most likely located in these communities. It means that NPs play a critical role in increasing access to patient care in the poor areas and rural areas. On this bar graph, you can see that this measure ADI, it's area deprivation index. It's an index that measures how poor and socioeconomically disadvantaged the neighborhood is, how less resources are in this community. So you can see yellow means practices with NPs and gray means practice without NPs. As you can see, as ADI gets higher and higher, which means its neighborhood gets poorer and poorer, more clinics are hiring nurse practitioners. So this tells us that nurse practitioners play a critical role in delivering care to patients in poor areas. But also nurse practitioner numbers who are specifically trained in geriatrics, right? Because geriatrics is the one that delivers care to older people. Their numbers are increasing. We did another study here. You can see yellow is the GMP. It's a geriatric trained nurse practitioner. These are nurse practitioners who deliver care to older adults. And GMD, these are geriatric medical doctors. As you can see from 2010 to 2020, for 10 years, the number of geriatric physicians were slowly decreasing, while number of geriatric NPs is increasing. This tells us that, and these are some of the differences we noticed, that the national per capita supply of geriatric physician decreased by 12.7% between 2010 and 2020, and while the number of NPs increased by 125%. So what this tells us that, well, as the population gets older, and nurse practitioners are going to take more and more responsibility to deliver care to older patients. So this is the background and some of the studies of my team. So, but it doesn't mean that if nurse practitioner numbers are increasing, all the issues that nurse practitioners face is going to be addressed. There are many federal level issues, which is higher government level national issues that affect nurse practitioners. One of the biggest challenges is that insurance company, it's called Medicare, that is a federal national level insurance for Americans who are older than 65. It that pays only 85% of the physician fee for nurse practitioners. So, which means if the patient comes to see a physician, the insurance company pays more money than if the patient comes to see a nurse practitioner. And this creates a big issue because then patients can get a care by nurse practitioners, but the billing is done by a physician. So this is a big issue that affects a lot of nurse practitioners in the US. This is a US map. There are also state level issues. As you know, the US is a big country. There are many states with many rules and regulations. So in this map, green states are the ones where nurse practitioners can freely deliver care to patients. Nurse practitioners can go to the school, get educated, get their licensure, and then they go and practice without any restrictions. These green states are called full scope of practice states. Then you have yellow states. Yellow states say, okay, you can do everything you've learned and educated and passed your licensure to do, but you need to have a physician who says, I agree to work with you before you can actually practice. So these states are called reduced scope of practice states. And then, of course, you have a few of the red states that say, nope, you need to have a physician to supervise you before you are able to practice. So even within the US, you can see that the state level barriers are creating a challenge for nurse practitioners. For example, if you live in a green state and you suddenly move to a red state, then you cannot do your job because red state does not allow you to do things you've done before. So these are type of the state level issues that even though nurse practitioner role has been in the US since 1965, we still see this type of issues. And I know in Thailand, nurse practitioner role is much younger. It started in 2000. But I just want to share with you that, just because in the US it has been around for a long time, it doesn't mean all the issues have been solved, okay? So my team and I did a study saying, the state scope of practice restrictions are not good. You should not restrict NPs from doing their job. We published this study where we show that if NPs are allowed to practice fully, then this way we can really reduce cost of care and really improve patient outcomes. So consistently, our research shows that state level policies have to allow NPs to practice with the fullest extent of their education and licensure. So I told you some of the issues at the higher government level, now some issues at the state level. There are also issues at the clinic level, at the organizational level. So even NPs practice within the same state, every clinic can have their own organizational rules. So some clinics say, no, you can do this. Some clinics say, no, you cannot do that. So there are also organizational level barriers that affect nurse practitioners within the same state. So many years ago, then I decided with my team, can we understand why some clinics are good places for NPs to work and other clinics are bad places for NPs to work? So we developed this instrument called Nurse Practitioner Organizational Climate Questionnaire, which measures the work environment of NPs within the clinic. And we developed it about, like 14, 15 years ago. And now the tool is being used widely across many countries trying to who study the MP workforce. So the instrument has 4 subscales. It has 29 items. And the items ask nurse practitioners to rate the degree to which the certain type of work characteristics are present within their organizations. So it asks questions, tell me about your relationship with the physicians, teamwork, communication, support you get from administrators. Are you able to practice to the fullest extent of your education? And do people know what is your job and what are you supposed to do? So these are this tool we usually use, and we send. It's a survey tool. MPs can complete the surveys on their own, and it measures the work environment of nurse practitioners. So using this tool, we have done many studies. We've surveyed MPs in 6 states, trying to understand if MPs who work in those green states have better work environment. Because if the state is allowing MPs to do their job, then it is possible that organizations are also creating a good environment for nurse practitioners. And this is a title of our publication. So we have several papers, and you'll be happy, please happy to share my slides if you want. So using that tool, we also wanted to see if MPs who work in a good environments, are they more likely to be satisfied with their jobs and say, oh, I'm not planning to leave my job? So, because if we find out that the good clinics are able to keep MPs, then we can go to the practice leaders and say, if you improve the work environment, then nurse practitioners are not going to leave their jobs. So we have done many studies, and throughout all of the studies, we have demonstrated that working in a good practice environment really improves nurse MP job satisfaction and reduces MP turnover. But we also said, okay, now that work environment is good for nurse practitioners, we can show that this is is it good for patients? So now my team and I asked the next question, does work environment affect patients? So what we did in this study, we surveyed nurse practitioners, and then we got the patient data from those clinics and merged those data, and we showed that clinics where MPs are telling us they have a good work environment, their patients have better outcomes. So you can see how we started from instrument development, work environment measurement. Then we went to see how work environment affects MPs, and then how work environment affects patients. So that's how we build a program of research. So when you think about your own program of research, think about how to build step-by-step projects on each other. But one of the biggest things that my team and I were interested is, can we effectively use nurse practitioners to reduce health disparities? One of the things about US is that health disparities are a major issue. And many people in the US don't have access to high quality care. And with my colleague, we developed this model that says if you create good regulations for nurse practitioners at the state level, if you create a good place for MPs to work, then more MPs are going to work in those communities and in these clinics, and then you will be able to improve access to care and reduce health disparities. And most of the health disparities are among racial and ethnic minority patients. We know that in the US, there are Black and Hispanic patients who don't have the same outcomes as white American patients, but which is a problem. So we're trying to figure out, are there ways to really effectively utilize nurse practitioners to reduce those health disparities? And we have multiple studies about that, where we show that if you improve work environment of MPs, and this is, I think, one of them we published, that if you improve the work environment of nurse practitioners, then you're able to reduce hospitalizations and emergency use among chronically ill older adults. Medicare beneficiaries, these are people who are 65 years and older, because MPs are involved a lot in chronic care delivery. Okay. Any questions? I'll be happy to stop and answer any questions if anybody has questions so far. Are you following me? Okay. So because I'm hoping throughout this lecture, I will just walk you through how you can go from one topic to another to build your program of research. Okay. So far, I've mentioned to you that many MPs work in different neighborhoods, right? Where there are low education, there's poverty, there's low access to healthcare. So we have this study from the government where we're trying to understand if MPs in these communities can help deliver better care to patients. So this is the aims of this study. So what we're trying to do in this study is to see if MP practices where the clinics that MPs work can really help to deliver care in communities that do not have a lot of economic resources, where they don't have a transportation and how patient how patient drive to get to their clinics, where patients also have education, health literacy is lower, trying to see if MPs can really tailor their care to help reduce health disparities in these communities. So as the number of MPs continues to grow, they're playing a critically important role in these communities. So as we're doing this research, and as we're seeing that many older Americans are having chronic diseases, one thing that emerged from our research was that a lot of older Americans are starting to have dementia because the number of dementia is growing significantly in the US. And my team and I asked the question that, oh, dementia is a chronic condition. If it's diagnosed, our job is to deliver good care to these patients. Can we use nurse practitioners to deliver good care to patients with dementia so these patients do not go to emergency rooms, these patients do not go to the hospitals? We wrote a paper about it, and then another paper was written about our paper saying that, oh, the researchers are right. Nurse practitioners are a perfect fit to deliver care to patients with dementia. We know that some numbers say that about 7 million Americans live with a dementia, and they do not really receive continuous care. So this is a conceptual framework that guides our study. Here you can see in the red where we're trying to show that can MPs deliver continuous care to patients with dementia so these patients do not go to emergency rooms and hospitals? One thing we're noticing when we started doing dementia research is that patients go to hospitals too many times. And they go to emergency rooms for things that they don't have to go. And we know that nobody wants to go to emergency room. It's not a good place for patients. There's no continuative care. There's risk of errors and mistakes. So we built this study to show that if patients who get continuous care from MPs, then they are more likely not to go to emergency rooms and hospitals. So the study were in progress. Okay, so you see how we're moving from outcomes to MPs to dementia. But one of the things that we also study in my team is that nobody delivers care alone. You need to have in order for us to deliver high quality primary care, it's really important for us to develop teams, good teams that work together, because we know that when you have a good team, patient outcomes improve, clinician satisfaction improves, teams can see more patients, it improves access to care, and it improves patient experience. Let me show you one thing. What do you think this is? Anybody wants to say what do you think this is? Or on the Zoom, anybody wants to take a chance and guess what this is? Okay, so let me then tell you. So in what we did in one study, said, okay, if teams are really good, what do the teams look like? And we went to 23 clinics and collected data, everyone who worked in the clinic. And we use this method called social network analysis to see the teams. So these are healthcare teams in different clinics. So you can see, like, for example, these dots are people who work in one clinic. More dots and more lines, it means more people are working in this clinic and there's a lot of interaction. You see B is also a clinic. And you see C, these are all different clinics. You see how different they look like? So what we found out is that when we talk about teams, we really don't know what they are. And they look very different from clinic to clinic. And we really don't know how to design a good team to improve outcomes of the patient. So now my team is working on many studies to really understand how to design best teams to deliver care to patients, particularly those who are older adults and have chronic diseases. So I hope till here I showed you the progression, how you go from MPs, patient outcome, work environment, instrument development, and now team design. The other new trend that we are noticing in the US is that where else is primary care delivered? So primary care now is being delivered at homes. So there are many patients in the US who do not go to the clinics to get primary care. So they're at home because they're sick, they're obese, they have dementia. So in order to really help to take care of these patients, the nurse practitioner or a physician goes to patients' home to deliver care. This type of a model of care is beneficial because this allows clinicians to see patients' home, where they live, how they live. It also helps people to have access to healthcare. And research shows that if you have a good home-based primary care, then patients don't go to emergency rooms, and it improves patient satisfaction because patients feel that there is someone they can always come and ask for help. Okay? So who delivers a team home-based primary care? Home-based primary care is again delivered by a team of clinicians. This can include physicians, nurse practitioners, nurses, social workers. So there are a lot of people who are involved in delivering home-based primary care. With my team, we have a study where we said, can we understand the teams who MPs work with when they go to patients' home to deliver care? And also how it affects MP's job satisfaction, burnout, turnover, because a lot of clinicians don't like to go in someone else's home to deliver care. So we wanted to make sure that MPs have support, they have good team to work with, so they keep doing the job, right? Let me show you another figure now. And I think now you know what this means. These are MP teams. So we asked MPs, who do you work with when you go someone's home to deliver care? So you can see in the figure A on the top left corner, MP lists a lot of people. They work with pharmacists, they work with other nurse practitioners, they work with a manager, they work with physical therapists, social workers. So there are a lot of people MP told us they work with. On a big figure, MP only says two people, another physician and nurse practitioner. So this MP does not have a lot of support. And as you can see again, how teams vary from nurse practitioner to nurse practitioner, telling us that they don't have access to the same resources and support to deliver care. Make sense? Are you following me? Okay, good. So now my team and I are studying home-based primary care, trying to see if we can deliver better care at patients' home. But we also know that a lot of older people are in nursing homes. We know that about 1.2 million Americans right now live in 15,000 nursing homes in the country. And I'm sure you remember during COVID, all of the issues that nursing homes were having. And consistently, nursing homes are looking to find better way to deliver care to these patients. to adults who live in nursing home. So we have a project where we are trying to see if nurse practitioners who work in nursing homes are they using the technology to improve, help them deliver better care to residents in our nursing homes. So for this study, what we're doing, we're collecting data from all nurse practitioners who work in the nursing homes and merging it to resident data, nursing home resident data, to see if nurse practitioners use technology, they have a good environment to work, then patient outcomes are better. So you see, so you see how we went from NP instrument, work environment, patient outcome, teams, home-based primary care, and nursing home, trying to see that and how each study led to next study. Does that sound good to you? Okay. So, so all this work is ongoing. So it's not that we're finished. We have more questions to test. We have more questions to ask. That's why we train the next generation to help us to do more research, because I cannot do this by myself, right? So this is my office building, and we have this program called T32 System Science and Comparative Cost Effectiveness Research Training, where we train PhD students, we train postdoctoral trainees to conduct more research on these topics. And then we also brought together, I think we brought together experts to say, okay, we have studied so many, we have done many studies on MPs. What are some of the next research questions that we have to study when we're doing a future research with nurse practitioners? So, and we brought together experts who are coming from many, many countries, and we came together and we're asking questions, what kind of research we should do to move the science forward. And here the paper is published. So if you're interested in reading, it's been published. So what experts were telling us that it's really important to learn how to translate evidence from practice to change patient care in the ground, to translate into a better care, cost-effective care, quality care, and how we can also attract different people to come into nurse practitioner workforce. So I hope I showed you how MPs are really important, and I know their numbers are growing in Thailand, and MPs can really help to eliminate health disparities, and they can also help, but we still need research to advocate for removal of the barriers that MPs face. I spoke to you about federal level barriers, state level barriers, and organizational level barriers that MPs are facing. But one of the big things that I'm very excited about is training the next generation of nurse scientists, because it's really important to really have very strong nurse researchers to continue doing this work and continue doing producing evidence to really help grow the workforce and help patients to get access to high quality care. So these are some of the topics that my trainees have been studying. So I have PhD students and postdoctoral students who study substance use in rural areas, multiple chronic, how to deliver better care to patients with multiple chronic conditions, serious mental illness, limited English proficiency, and palliative primary care. So every year students are joining our team and conducting different type of research. So hopefully to produce more evidence to impact change. And these are some of the titles of our projects that we're working on. So hopefully, when we complete these studies, we'll have really a robust body of evidence to help guide some change. And these are some of the organizations that give us money to do this work. So we cannot do work without funding. So that's what I had planned for you. So thank you so much for listening to me. So I hope this is what you're hoping. I know nobody can listen to anybody more than 30, 40 minutes. So I stop here if you have any questions, I'll be happy to answer. Thank you so much. Okay, go.
I have one question. Currently, this is the technology for the NP nurse. Please you give the more detail on this topic.
Sorry,
The technology on
yeah,
take care of patient in the home care
yeah.
and including the NP pass. Please you give me more detail in
Okay,
this.
of course.
Thank you.
Yeah, thank you. That's a good question. So if I can talk more about the study that we're doing about technology used in nursing homes. So that study, because in nursing homes, patients live there, right? So they live there all the time. It's their home, and many of them have dementia already. So what we are doing is we're collecting data from administrators from the nursing homes, leaders, to see what kind of technology they have, because some of the nursing homes don't have any technology. So we are asking questions. We have this instrument called HIT Maturity Index, a Health Information Technology Maturity Index. So we're trying to see what kind of technology do you have, and then we're also asking nurse practitioners what kind of technology do you use them. So some of these are recording patient status, some of them are communicating with other providers. So what we are finding out that there is a wide variation. So some nursing homes might not have anything. Other nursing homes, they might have it, but MPs are not using it. So, and then what we're going to do, we're getting the patient outcome data from these nursing homes, and we're going to try to see uh, nursing homes that have a better technology use, are their patient outcomes better? So the study is in progress. So when I come back next time, I would have the results. Did I answer your question? Okay. Thank you. Okay.
Good afternoon, Professor. I'm the third year PhD student of Chiang University. I'm Annie. Nice to meet you.
Very nice meeting you too.
I have one question related to the patient outcome, because I think patient outcome actually it is a broad term, and I just wondering that how do you measure the patient outcome from the symptoms or something else? Thank you very much.
Oh, no, thank you. That's a very good question. And you're absolutely right. There are a lot of things that can be considered patient outcomes. So, in most of these studies, we use emergency department use or hospitalization. We say that if we deliver good primary care, then patients should not go to emergency rooms. It's fine if someone breaks their leg, they can go to emergency room. But if you have a diabetes, if you have an asthma, that if you well managed in primary care, then you shouldn't go to the emergency room. So in most of these studies, we define them by preventable. So there are certain kind of emergency room visits that you can prevent. So we measure by either preventable ED visits and hospitalization, or we measure by all cause ED visits and hospitalization as patient outcomes. Did I answer your question?
Yes, yes, Professor. Thank you very much.
Thank you for your question.
From the home-based care, do you have some medical professional who control your your work or some your role to do the home-based care?
Not really. One of the common things now that's happening is that nurse practitioners are opening their own clinics.
Oh,
And then they can decide, I'm only going to do home-based care.
oh yes.
So in many states, nurse practitioners are the number one providers of home-based primary care. So nobody, MPs control their own.
Yes.
Yeah, especially, and it's becoming very popular.
Mm.
And I have a colleague who works with me in the center that she specifically studies MP-owned practices. That clinics that MPs open, and there are many of them do home-based primary care.
Oh yeah.